A very good morning and a happy new year to one and all. I, Dr. Manasi Shahane,
and I, Dr. Freddy Kheshwala, welcome you all to Guidelines 2019. We hope you will enjoy the feast of knowledge we have set out for you for the next few days.
Now without a further ado, we would like to start the session. I request the chairpersons for the first session to come on the dais. Our first chairperson is Dr. Atul Mule. He's a consultant nephrologist at Dinanath Mangeshkar Hospital, Pune, with a special interest in epidemiology. He's also a guide to DNB nephrology students.
Let us warmly welcome our next chairperson for the day, Dr. Pratibha Phadke. She is a senior consultant physician with us in the Department of Medicine at Dinanath Mangeshkar Hospital, with a special interest in pregnancy-related medicine and diabetes. Welcome, sir. Welcome, ma'am.
Good morning, everyone, on Guidelines 2019. So let us start the ball rolling right away. Our first speaker for the day is Dr. Deepak Bhonagiri. He is a clinical director for critical care, including anesthesiology, emergency medicine, intensive care, pain management, and also organ and tissue donation at Sydney's Southwest Local Health District, Sydney, Australia. He is going to speak to us on acute kidney injury. So let us welcome Dr. Bhonagiri.
All right, thank you everyone. So look, like they said, I'm from Sydney, where, as you know, the Indian team is playing Australia. And how many of you think Australia is going to win? No one? Okay, well, wait and see what happens. Things change. Anyways, yeah, look, thanks for inviting me here, and I'll get started. So I'll let you know about a patient that I saw here in Pune when I used to work here about 25 years or 30 years ago. A young man who came in with what at that time we thought was enteric fever. We fluid resuscitated him, admitted him to what then was a very rudimentary ICU, and gave him more fluid and gave him antibiotics, and he got oliguric, hyperkalemic, and looked like he was going to die. The only option we had at that time was to dialyze him, and there was only intermittent dialysis at that time. There was no continuous dialysis. And every time we took him out to dialyze him, his blood pressure would go to like 30, 40 systolic, and he'll kind of go to peri-arrest. Unfortunately for us, we couldn't save that man, and he died. And that's where my kind of little bit of ICU career here in Pune started. I then went on to do anesthesia and then changed to ICU back in Australia. So coming now to the topic that we're going to talk about, which is acute kidney injury. When I was training, it used to be called acute renal failure, but that's now changed. And that's because we now recognize that acute kidney injury, it's abrupt, there's a loss of kidney function, and there's also some structural damage. And the thing that's quite important to remember, especially for the young people here, it's a syndrome, it's not a disease. So it's not something that you can give an antibiotic and fix. It's a syndrome that comes from many diseases. The diagnostic approach we'll come to, and biomarkers, despite what we try, they're still nothing much better than the creatinine and urea and urine output. So these are the KDIGO definitions of acute kidney injury. So you look at your creatinine, and if it goes up, you classify your acute kidney injury into various stages, stage 1, stage 2, and stage 3. The important thing to note with the stages is that the outcome of patients varies according to the stages. So stage 3 has a worse outcome than stage 2 and stage 1, obviously. So that's the KDIGO definition of acute kidney injury. What's the epidemiology of this? And I noticed we've got here a renal physician who's interested in epidemiology. So this is what the KDIGO group thought the incidence was. So they think approximately 2,000 to 3,000 people per million get acute kidney injury every year. And the people who require dialysis or renal replacement therapy are 200 to 300 per million population, which is quite big. And that's the same as you'd see in terms of severe sepsis. So 4 to 5% of general ICU patients, so this is not the surgical, the neuro ICU, but general ICU patients, so they will require renal replacement therapy. And obviously it's got a huge mortality and a long length of stay. So in Australia, we did the renal study looking at 25 mils per kilo per hour of effluent versus 40 mils per kilo per hour of effluent. And then we followed up those patients for up to 4 years. So that was the post-renal study. The important thing to note there is about 60% of patients in both the groups were dead at 4 years. So that's a pretty big amount. But the other thing that you can note is in terms of renal recovery, if you present to ICU with acute renal failure, only about 5.5% of survivors are on maintenance dialysis at the end of 4 years. So there's a small proportion of them who need dialysis at the end of 5 years. So it's not a huge number. Now, when we looked at how these people died, I mean, what did they die of? So almost no one died of renal failure. And in the West, no one dies of renal failure because they're dialyzed. We dialyze patients who are 90. So that's never an issue. What they die of is the basic disease, the hematological malignancies, or they had a stroke and died, or they had other things and died. So none of them died because of failure to dialyze or other things. Most of the people who died of a basic other big disease like a chronic leukemia or something else that was diagnosed outside of their acute illness. So the diagnosis of acute kidney injury, look, as always, history is very important. We all work in emergency departments in intensive care units, and history is one of the most important thing, but the thing that's the most difficult to get. Because if somebody rocks up in extremis, it's very hard to get a history. So the important thing for trainees is go back and get histories. Maybe the first 4 hours are spent resuscitating someone, but then sit down with the relative if the patient's intubated, ask them the history. What happened? How did this start? How were they a week ago? How were they 3 days ago? How were they 6 months ago? And that is the most important thing because that will set out how the patient will do. And then, of course, your clinical examination, which may or may not give you anything. Acute kidney injury. Look, the trick for the new players is, and what I find especially in RED, is patients come in and they're very tachypnic. They're breathing and they think they've got a pulmonary embolism and they rest out to have a CTPA thinking that they've got a pulmonary embolism. And then somebody does a blood gas and they're severely acidotic, and that's why they're tachypnic. It's not because they've had a PE, but because they're trying to compensate for their metabolic acidosis because they've got acute kidney injury from some reason. Urine volume and analysis is important. You can do blood gases, biochemistry, and imaging. So with regards to urine, look, if you look at textbook, they say, oh, try and put a catheter. But if you work in ED and ICU, if you don't put a catheter, you've lost it. I mean, you've lost whatever little monitoring you have for your patients. There's a lot of surgeons especially who will tell you that putting catheters in is associated with high incidence of infection. But you don't have a catheter in, you don't know that your patient's anuric or in renal failure, he'll die in front of you, and that real catheter and the nurse telling you, look, there's been no urine for the last 6 hours, might actually push you to do things. So putting a catheter in, I think, is a no-brainer there. This is the urine analysis that you can get, and that will help you make a diagnosis. But you don't do this in ED straight away. You might wait and do this in ICU. This is a busy slide. I've left it there just so that if the slides are passed around, you can get an idea of this. And this is more for trainees who will give examinations. So examining the urine, looking for casts and so on is very, very important. And it will occasionally give you a diagnosis that you can cure or treat in the long term. So the blood gases, as I said, this would be kind of the typical blood gas you get in acute renal failure. So you'll get a patient who's acidemic, who's got compensatory respiratory alkalosis, so the CO2 is low, the bicarbonate is low, there's a high anion gap, and they're hyperkalemic. So that's the kind of blood gas you get. That's the kind of thing that would worry you, and you jump onto this patient in ED and start urgent treatment. And the urgent treatment, as you all know, essentially starts off being medical treatment. So you treat the potassium in the first instance because that's what's going to kill them the first, and you treat it with your calcium gluconate or bicarb or dextrose insulin infusion. So that's the first thing you'd do, and then you'd slowly try and work out and treat the acidosis and other things. So the renal biochemistry, so despite all that's written and all the literature that you read, the creatinine and urea are still the gold standard for diagnosing renal impairment or renal failure. The rate of rise of creatinine and urea are quite important. A change in value from the baseline is what's more important. With the incidence of diabetes being so high, especially in this country, you'll have a large population of patients who come to you who've got acute and chronic renal failure. So if you know somebody's creatinine has been up before, but it's doubled and they've come to you, that's how you diagnose the acute and chronic renal failure. And that forms a significant proportion of patients you'll see coming into your emergency departments and your ICU. In our place, we now get what we call the eGFR, or the estimated GFR, which is which is calculated using the creatinine and urea. If you get this here and you're working in an emergency department or in an ICU, just ignore it, please. Do not ever pay any attention to it, because it's not validated in the acute setting. It's only validated in patients who are stable and whose volume status is good and whose volume status doesn't go up and down as it does with sepsis. So the eGFR is not validated in acute critical illness. The rate of rise of creatinine is helpful, and it especially helps you decide how to dialyze things. So when we do renal research, we try and put together something that says if your creatinine doubles in 6 hours, that's an indication for dialysis, and so on and so forth. And a urea creatinine ratio is quite important. Firstly, it'll tell you that your patient is dry. So if the urea is very high and the ratio is more than 20:1, certainly your patient needs a fair bit of fluid. The other trick is if your patient's bleeding, especially has a gastric ulcer, which is quite common in patients with acute renal failure, the urea may go up because they're digesting the hemoglobin and the urea is up. So that's another trick that you need to learn about. So this is just to give you a graph of the rate of rise of urea and creatinine. What you'll note there is the creatinine clearance, which is what you're really trying to find out. That drops quite quickly, but the creatinine, the lag time of creatinine, or the half-life of creatinine is much smaller. The other trick that everyone needs to realize here is you have what we call the little old ladies, so the patients who are 80 who've got very little or no muscle mass, and in them a normal creatinine that you would see in a young healthy adult might actually be very, very abnormal. Because their muscle mass is low, they will not produce the creatinine that you see in the young healthy patients. And that's why it's good to keep it in context and to treat your patient rather than treat a number. So the test for the causes of AKI, these are very important, and every time you have somebody in your ICU or in your ED, once they're admitted, very important to call a nephrologist, because they'll tell you to do most of these tests. Many of the times you might think, why am I doing these tests? But you'll find occasionally your patients have one of these problems that are going to be a long-term problem. It'll be the first diagnosis of maybe an ANCA-positive vasculitis, and you can imminently treat it with immunosuppressants, and the patients will get better. If you don't treat it with that, they'll still continue to go on. You'll continue to treat it as sepsis, but they just won't get better. The other thing in the emergency department, if somebody comes in, you put a catheter, there's zero urine, do a CT KUB. The number of times somebody comes in with a completely obstructed renal tract that can be treated surgically is not inconsiderable. And there's a population of patients out there who have a single kidney that's undiagnosed, and if that gets blocked by a stone, that's it. They're going to come to you anuric in renal failure. So the biomarkers, so these are all the new, what we call novel biomarkers, although they should no longer be called novel because they've been around for many years. Of this, I think NGAL, the neutrophil gelatinase associated lipocalin, I think that's the one that is now being promoted and has the most potential in terms of diagnosing kidney injury early in the piece. The rest of them, the interleukin-8, it tends to be useful, but in sepsis it's not really very helpful because it's not very specific for kidney injury. So this is the NGAL values post cardiac surgery, and that gives you an idea of the renal failure, and people have used validation algorithms for this, but it's still not something that's used commonly, and certainly I've not seen it being used outside of a research setting. So the causes of acute kidney injury, they can be pre-renal, as you know. So people who come in with sepsis, hemorrhagic shock, cardiogenic shock, or shock of any description. So they come in with ischemic acute tubular necrosis that looks like the slide up there. And then you've got all the intrinsic renal disease, the glomerular ones, the tubular ones, the vascular, the interstitial ones. And those are the ones that you tend to be able to treat with either steroids or immunosuppressants or specific therapies. And the post-renal, the ones that we spoke about, the obstructive kidney disease. So in my mind, what I need to know as an ICU person or as a critical care person is this an oliguric or anuric failure, or is it a polyuric failure? That's quite important for me because I need to know, can I give them volume, or should I stop giving them volume because they're in pulmonary edema and start dialyzing them? If they're in polyuric renal failure and passing about 1 liter of urine every hour, I need to be careful that I'm replacing the amount of urine that they're passing. So that's what's important to us as critical care physicians in terms of practical classifications of AKI. Is it acute or acute on chronic? Because then you know how to treat it. Because a chronic renal failure, they'll go back to their baseline creatinine at some stage, and then you've got to hand them over to the nephrologist and they'll continue to look after them. Is it surgical? Is it a perioperative renal failure? Is it because they had 2 liters of blood loss while they were having their surgery? And is it acute kidney failure because of that? Because then you replace the blood, give them volume, they will get better. Versus the medical ones that tend to last for a bit longer. So the septic AKIs take a bit longer to resolve as opposed to the post-surgical ones. Is it isolated AKI? Is it AKI that's because of some ANCA-positive vasculitis or a glomerulonephritis? Is it like an intrinsic renal problem, or is it part of the sepsis syndrome or part of something multi-organ dysfunction? Because if you treat the multi-organ failure, the kidneys will recover. And is it pre-renal versus intrinsic? So this is what we need to know as acute care physicians in terms of practical classification. Now, this is the classification that's used by epidemiologists, by people who do research, and this is the stuff that in future will tell us how kidney failure or AKI is going to behave. So the rifle criteria that's up the left there, quite important, well validated now, the AKIN classification and the KDIGO classification. These are the three that are used, and they've all been validated, and they're all equal in terms of their specificity and sensitivity to diagnose kidney injury and to look at it epidemiologically over millions of people, millions of population. So they're all validated, but there'd be more research. So I've hardly ever seen a nephrologist come to me in my ICU and tell me this guy has rifle criteria 3 or 5, and therefore you need to dialyze this patient. He'll still tell me the creatinine's high and whatever, and dialyze him. So they're used more in epidemiology rather than in clinical practice. So this is again the rifle criteria, because that's the one that's used quite a lot in our research basis. What we need as clinicians really is a classification that'll tell us this patient needs dialysis, this patient doesn't need dialysis. This patient will recover with dialysis, this patient will recover with diuretics. There's none of this at the moment now. NGAL maybe has a bit of potential, but there are no tests at the moment that will tell you if you hit this patient with like 200 milligrams of furosemide, they'll go into a polyuric phase and they'll continue to recover. So you don't need to worry about dialyzing him and putting in catheters to do that. The other thing to remember, which I think is quite important, is AKI is a syndrome. It's not a disease. So you're not going to be able to treat it with one thing. Treat the cause of the disease, and the patient will get better and the kidneys will recover. So kidney failure is one thing that you can prevent. So in among a lot of diseases we see in ICU, you can't prevent a lot of things, but kidney failure certainly is preventable. And simple things, maintain euvolemia, maintain adequate renal perfusion, avoid nephrotoxins, and maybe some pharmacotherapeutic intervention. So keep your volume status up, monitor your volume status, try to keep them on the full side if you can for kidney failure. And the crystalloid versus colloid debate, we in Australia get albumin for very little money, so we tend to use albumin quite freely. It's very expensive otherwise. When we did the SAFE study in Australia comparing albumin to normal saline for fluid resuscitation, we found that there was no difference in mortality or the incidence of or outcomes of kidney failure. So really, I personally don't use albumin quite as much as some of my colleagues, and I wouldn't certainly recommend it as a resuscitation fluid. If in protocolized therapy, as in post-cardiac surgery and things, maybe there's a role for colloids. Certainly, after the 7S study and the other studies that we've done, there's no role for hydroxyethyl starch. It's been shown to cause renal failure in otherwise normal patients. So that's something you should try and avoid. Looking at volume status or maintaining euvolemia, mean arterial pressure is what we go by, urine output is what we go by. The CVP, probably not that important, and the PA catheters, they're not used in common parlance anymore. So looking at renal perfusion, remember autoregulation for the kidney, there's a wide margin between 80 and 160, the kidney autoregulates its own circulation. So if you go below that or above that, you're likely to get into trouble. I used to be an anesthetist, so I can say things about anesthetists. Anesthetists try to make surgeons happy. So they'll keep the blood pressure very low, all through the case. So you look at the anesthetic chart, and it'll be a 6-hour case, and the blood pressure is at 80, 70, 80, 70, 80, 70. And just before they bring them out, they'll whack them with some vasopressor and bring them out, and the blood pressure is fine. And then you wonder why this patient's not passing urine, got into kidney failure. Guess what? For 6 hours, they've had no urine, they've had no fluid, their blood pressure has been low. What's going to happen to the kidneys? So, you've got to go back and look at this and try and maybe educate the anesthetist. The anesthetists seem to think that this is, something that's very good. They try and impress their surgeons. Avoid nephrotoxic drugs, the antihypertensive, the antibiotics, non-steroidals, and contrast dyes. So this is just a graph about renal autoregulation. Antibiotics, so the cephalosporins, the gentamicins, and the vancomycins are things that you've got to be careful about. And where possible, get your peak and trough levels and base your antibiotic dosing on that. Non-steroidals, certainly the traditional non-steroidals do cause renal failure. When I started, we used to use a lot of indomethacin and see a lot of patients end up with renal failure. Contrast-induced nephropathy. Look, this is getting to be a bit more of a common problem because lots of patients go in and they get lots of contrast for angiograms or interventional procedures, and they're hypotensive or other things. So they get multifactorial renal failure and need to be dialyzed for that. So prophylactic, I think normal saline and bicarbonate are the things that work. So volume is the best thing. I'll skip through a few slides. With the pharmacotherapeutic things, look, none of them really prevent renal failure, but you can use them. Dopamine has no role. We did a big study in Australia looking at dopamine for renal protection. It really doesn't work. All it does, it increases your blood pressure, and that's how your renal failure is avoided. So what about renal replacement therapy? These are the indications. So volume overload, hyperkalemia, metabolic acidosis, uremia, and drug intoxication. So intermittent versus CRRT versus the intermediate therapies. Look, there's no thing that says one is better than the other, but remember that most of the patients who are included in the trials or excluded in the trials are the ones that are hypotensive and who continuous therapies are indicated. The best kidney study showed that CRRT was the most common, at least in the Western world, and in Australia that's 100%, whereas in North and South America they still use intermittent hemodialysis. And that's just because how things work in the two countries. We run our own dialysis in ICU as intensivists. In some other countries, you need a nephrologist to start dialysis. So that's why there's a variation in how things are done. CRRT studies, so there's a recent study of early versus late initiation that showed no difference. And importantly, about 50% of patients in the late arm did not get dialysis. Again, remember that the patients who had hyperkalemia, severe metabolic acidosis, or anuric renal failure were excluded from this study. So this is not dialysis for salvage, but this is dialysis in those who had a doubling of creatinine and other things. The dialysis dose, we did the renal study, and that showed that doing a lot of dialysis is no better than doing less dialysis. And citrate is probably better. We are using a lot of citrate dialysis in Australia or in our centers, and we find our filter life is much better, and we find that that saves us a lot of money. There's no big studies on when to stop dialysis at the moment. My practice is, look, I use the IVC diameter to work out how full the patient is, and that helps tell me whether they've got enough intravascular volume. Use vasopressors early. I trial furosemide in patients who are hemodynamically stable, who are not on big doses of noradrenaline. I rule out obstructive uropathy. I start dialysis a bit earlier than my colleagues, just because I think if you're going to need it, you may as well just start it. And I do at least twice daily renal biochemistry if I think there's going to be a risk of renal failure. And the most important thing I think for all of us here is participate in big clinical studies in whatever way you can in AKI, because there are studies that have made a big difference to patients' mortality and also the cost, which is very important, because we've stopped doing things that don't work, such as doing 40 mils per kilo effluent dialysis, early dialysis. So there are a lot of things that you can do that you think work, but really don't work when you look in big studies, and you can save your patients a lot of grief from getting accidental pneumothoraces or a lot of bleeding from putting in dialysis catheters, and you can save them a lot of money. So that's one way in which you can look at equivalent studies. So there's a lot of studies still to be done in AKI, in ICU, and emergency medicine. So that would be my take on this topic. So happy to take a question or two if there's time. Otherwise, thank you for listening to me patiently. Okay, so the MCQ, which of the following strategy is applicable to prevent contrast-induced nephropathy? Oral fluids, N-acetylcysteine, prophylactic hemodialysis, or oral N-acetylcysteine? I think we've talked a bit about this. I expect 100% of you to get it right. All right, you've all voted? Yep, great. All right, fantastic. So oral fluids, good. N-acetylcysteine, still got a few takers for that. Prophylactic hemodialysis, that's good. And oral N-acetylcysteine, not bad. Yeah, fluids, I think fluids, as most of you say, is what I would promote. So I think most of you are right in there.